Welcome everyone to the Early Recognition and Management of Sepsis through Superior Health Quality Alliance. This is our first session today. And we might wait a few more minutes for some more people to join, but while we're waiting, if you wouldn't mind just putting your name, your organization, and your position there in the chat, we'd really appreciate that. That would be great. All right, well, we do have a lot of content to cover today, and so I think we will get going. So good morning, everyone. I'm glad to see people today. I know, as I was saying earlier, Michigan, we had a little bit of a stormy night, so I know some people were without power and that sort of thing. Hopefully not the same for Minnesota and Wisconsin people, but very glad that you could join us this morning for our session. So as I said, this is Early Recognition and Management of Sepsis. This is one of our structured collaboratives through Superior Health Quality Alliance. I'm Barb Link, one of the quality advisors here, and I'll be providing a short overview of the course, the content, a few housekeeping items, and then I will turn it over to our presenters for today, Josh Sawyer who is also one of my coworkers and a quality improvement advisor with Superior Health Quality Alliance, as well as Eric Wilson, who's the Director of Nursing and Quality at Optimal Care and has been a facilitator for this program in a few prior sessions. So welcome. A little bit about housekeeping. We do appreciate if you would keep yourself on mute unless you're asking a question. And hopefully most people are familiar with the Zoom platform now, but there is in your upper right-hand corner, if you scroll over it, there's a little blue box that says mute, and you can click on it, unmute yourself to ask a question. We will have more of a formal presentation format, and then you could ask questions more at the end of the presentation. But if there's something that you're really wondering about as we go along, we're open to open discussion as well. This is sort of an all teach, all learn format that we're working in. And so you can always chat in your questions. I'll sort of be manning chat for today. And you can always raise your hand, and we can go to you and you can ask your question as well. So this is an evidence-based and best practice education and training. We've got protocols and tools necessary for early recognition of sepsis. We will also go over some infection control throughout the program as well. It's case-based, interactive, and integrative team approach with all health professionals. This particular module is focused on the home healthcare setting, but we do have some participants from other settings that we hope that you can integrate it into your care setting as well. It's quite adaptable. It includes utilization performance improvement plan methodology, and also there will be some data collection over a period of improvement of the project and beyond. And we will be teaching you how to actually use the screening, teach the screening to all levels of care at your particular facility, and how to track and trend the data as well for process improvement. So participating agencies will implement the sepsis protocol, and that involves, it will improve your screening and identification of sepsis, and it will improve identification of patients with sepsis. It improves early intervention for patients with sepsis with the hopes of reducing admissions and readmissions to the hospital. It reduces the severity of sepsis when admission is required, and assesses the current infection prevention practices for pneumonia, UTIs, and wounds. Those will be all content within the future presentations that we have. So it also implements one infection prevention practice to close the gap between current state and best evidence based practice for each infection. And it reduces mortality rates for those with sepsis. It saves lives. So we've seen these improvements across our previous trainings that we've had. It really does engage all levels of care at your organization. The goal is to educate everyone from physical therapists, occupational therapists, to your nursing staff, and really integrate it at all levels of care. As well with the home health agencies, we saw a large component of family education and family education on sepsis and infection control. And we have a whole module within our toolkit that we will provide to you at a later date with that information as well. And I would say the majority of the organizations who received that information really appreciated to provide that education to their patients and their families. So what our expectations are for you. We want you to implement the sepsis screening tool and training protocols as provided in the training that you will receive. We want you to participate in the monthly sessions and then participate in optional coaching calls that will happen between session 1 and 2. We really would like you to reach out to the facilitators if you're having an issue or needing assistance, and they would be happy to set up a time in between the sessions to provide you that coaching and support that you may need at your organization. And then also the submission of process data. And we will be going over that too in the training as well. So we plan on having at each session a breakout session, just because now today it looks like maybe we could all stay in one room. How many total? We have 11 participants. Maybe for today we could just stay in one room. In future, as it expands, we would have a breakout session where we would be doing round robin. And again, that is the component where it's all teach, all learn, where people would be talking about what they learned from the last session, how they implemented the specific protocols and procedures, how that worked for them, challenges they had, and other people will be sharing what they did. And hopefully there would be support generated within that round robin session, and the consultation from the facilitators will occur at that time as well. So what we would like to have you do is share your agency name, your role at the agency, and what work you've done so far in the arena of sepsis, any current protocols that you have, and any standardized processes that you've implemented in that regard. So yeah, it is looking like we have about 11 participants today. So with that, why don't we Eric, Josh, are you okay with everybody staying in the same room for today and just doing the round robin that way? Okay, we'll go with it that way. We had a large registration, and probably at future sessions we'll be splitting off into a group. But this way we will just introduce ourselves and talk about sort of a little bit about sepsis and what you're doing at your agency. So again, I'm Barb Link. Oh yeah, Eric, yes.
If they could add in, we forgot to discuss this, but it's helpful to know what software they use for their health record.
Yeah. So any EHR information that you have, that also is helpful, because we've learned some EHRs, you have it already, some things built in, or how easy it is to build the sepsis screening into it, and that kind of thing is very helpful to know. So thanks, Eric. Yes. So that would be the last thing, is what EHR system are you using? How about we'll start off with our two facilitators today and just have them introduce themselves, and then I will just go around as I see people on my screen. So Josh, would you like to introduce yourself?
Sure. Thanks, Barb. Good morning, everybody. My name is Josh Sawyer, and I'm a Quality Improvement Advisor with Superior Health Quality Alliance. I'm one of the facilitators on today's call, and in a previous life, prior to joining Superior Health, I've been a nurse for about 10 years, and I worked for several years in the hospital environment as a sepsis coordinator, kind of building the sepsis program from the ground up. We really had no protocols. So kind of developing that screening tool to, developing how do we have clinical alerts? What are our processes? How does nursing supervisor know within X amount of time how to respond? How do we get early identification and get lactates on, get boluses on, all that stuff. So, so lots of experience from the acute care perspective. And I know Eric has a lot of experience on the home care perspective. So I think our work really complements each other. So yeah, I'll hand it over to Eric.
Thank you, Josh. My name is Eric Wilson. I'm out of Michigan Optimal Care Home Health. I'm the Director of Nursing and Quality. And I've been a nurse for 11 years. And I started in the emergency room and transitioned to home health. Where in the emergency room we did we had several sepsis protocols as far as timing of administration of antibiotics, as well as obtaining blood cultures. And then transitioning into the home health side was really nothing until, I was probably 5 years into home health, where we really started to look at this, maybe even 7 years. But I can kind of go through and, for the introduction, and kind of talk about what our agency has evolved into over the last 3 years that we've been, 3-4 years that we've been kind of taking it from the ground up and building our sepsis program, as well as our infection prevention and control. So, So thus far, the work on sepsis that we've done, we use WellSky or Kinzer software for our electronic health record, and we actually use the progress to goals feature, which we were able to build our sepsis screening into. So every skilled clinician, so PT, OT, nursing, speech, does a sepsis screening on each visit, and they have easy access to sepsis screening. So they have a flow chart within their home health admission pack. They also have an uploaded screening tool to their handoff, so that they always have access. Now they've all been doing it so long, they probably don't even need to look at the tools. They know the screening, but they do have it for reference. And then patients, built into our admission packet, patients are provided with some of the tools that you guys will receive. So the infection stoplight, hand washing, wound care performance, UTI prevention. And as far as from a quality standpoint, what we do is we do a random, and yes, we continue to do quarterly audits. So we do random quarterly audits on those charts to look for sepsis screening, and was it performed, and was it performed accurately, and was there follow-up done for positive screenings? And then we kind of dig into those cases where patients are admitted for those. So we have a lot of standardized processes that we're in. I can tell you, when we started the sepsis program, we had about 10% compliance once we rolled out at large. And it just took repeat education and maneuvering within the electronic health record and some one-on-one with the clinical staff to get to where we are now. We're consistently 100% compliance on our random chart audit. So that's kind of where we are now with this. And I guess I'll pass it off to Barb.
Eric. Okay. Sorry, I was trying to help someone else with technical assistance. So it might be nice to move on to Toni Kettner. She's one of our coworkers and quality advisors, as well as Superior Health. But just if you'd like to introduce yourself, Toni, that would be great.
Sure. Thanks, Barb. So as Barb mentioned, I'm a quality improvement advisor with Superior Health. And right now I'm working on the infection prevention and control goal team, and that's a cross-setting goal team. I think my interest in this is I've been a nurse. You all make me feel old because I've been in nursing for like 30 plus years. have experience in home health and hospice, acute care, managed care, and then of course long-term care. But before I came to my present position, I was actually the director of home care at Mercy Medical Center in Iowa, and we were actually affiliated with the Trinity Health System, which is in Michigan. We used home care, home base as the electronic health record, and that was something fairly new. We had just implemented that. To be honest with you, our focus between the hospital and home care system was mostly on our congestive heart patients, had a lot of protocols and processes around that, but quite honestly, not anything around sepsis. So I'm really looking forward to hearing about best practices and how we might help other organizations implement this kind of thing. So thank you.
Thank you, Tani. I see Connie Truska. Would you like to unmute yourself? And
I'm Connie Truska with, I actually represent two different agencies. I'm here with the Dancing Sky Area Agency on Aging, and we're just looking for different ways that we can assist or partner with different organizations. So that's kind of why I'm here for that. And I'm also the EMS director for our local ambulance service. And our medical director would like for us to really do more with sepsis as far as recognition and things like that in and out of the hospital setting. So we don't have any protocols, we don't have any processes or anything like that. We're just beginning the whole thing.
well, thank you. And many people are in the similar situation, Connie. That's why they're here today. So appreciate you saying that and glad you could attend. How about Cynthia Johnson?
Good morning, everyone. I'm Cindy Johnson, and I'm with Clinical Senior Care. I'm their wound program manager, and I have joined this call to learn the best practices in management of sepsis. We have our EMRs, home care, home base, and again, I'm on this call for learning purposes.
Great, glad you could be here too. Let's see. How about Lisa Wood?
Good morning. I'm Lisa Wood. I am from Hennepin Healthcare in Minneapolis, Minnesota. And I have also been in nursing for quite some time. So I'll tell you, it's been 30 plus years. And I won't go beyond that. But right now I'm the Clinical Quality Improvement Director, and I am also the co-chair of our sepsis committee, our org-wide sepsis committee. So I've been we've been working on sepsis for years. We do use EPIC as our EHR, and we have standing orders in place for nursing for the screening lactate. We have workflows for RRT, and we're actually right now looking at implementing care paths in EPIC, starting in our ED and then moving on to our inpatient. So it really flows with the care, and it's a visual so staff can see where the patient is at as far as antibiotics, repeat lactate, fluids, all of the above, and they can see it in like a snapshot type of a way. So I feel that we have some pretty good things in place for our hospital acute care patients, but when we were really looking at our data, we did see a lot of opportunity with readmissions and possibly some social determinants of health. And when I saw this was super exciting because in our system, we also have community paramedics, we have visiting nurses, and this may be an opportunity to learn how you've integrated that care into the community. And maybe we could take some of that back here and do similar work. And so I thought it would be really interesting to see what you've done and maybe try to standardize some of that in our community.
That's wonderful. That sounds great. I'm glad you're here.
Me too.
Let's see. How about Paige? Is it Paige Peterszewski? I am sorry. I'm terrible with pronouncing names.
That's okay. Good morning. My name is Paige Peterszewski. I am RN case manager and clinical coordinator at Riverview Home Care in Crookston, Minnesota. And we are really here just exploring. We don't have any protocols in place right now for sepsis, so we are open to learning. Our EMR, we use Epic in our agency. So excited for these next couple sessions to learn.
Great. Glad you're here. Let's see. How about Rhonda? I don't think I've had a time. Are you able to unmute Rhonda? Let's see. Maybe we'll circle back to her. Rhonda, are you on the phone? Let me see if I can. You have to, if you're on the phone, you need to press *6, I believe, to unmute yourself. Does that work?
Hi, this is Rhonda from Ellsworth Health Services. I'm the
great.
administrator here. So I just wanted to kind of sit in and listen and see what kind of information I could gather. I'm not a nurse in my background, so I just wanted to gather more information.
Wonderful. Well, glad you could join us today. I think hopefully you'll find this helpful. Okay, great.
Thank you.
I think, did I miss anyone? I think that is everyone. Okay. Right. All right. So with that, I will hand it over to Josh to start his portion of the presentation.
Okay, thank you, Barb. Thanks, everybody. All right, so as I said, my name is Josh Sawyer, and I'm a Quality Improvement Advisor with Superior Health Quality Alliance. Go to the next slide, please, Barb.
Sorry.
Okay, so today's session is going to be really split up between two topics. First, I'm going to kind of give a high-level overview of what sepsis is, why sepsis, why now, define early identification strategies, talk about best practices, and it's going to be pretty generic and broad. So the first part isn't going to be really honed in towards the home health care. It's just going to kind of be the why, some stats and things like that. And then once I give that basic overview, I'll be handing it over to my colleague, Eric, and he's going to dive more into the home healthcare screening process. And then prior to the next session, actually, everybody on the call will be given a toolkit, which includes several patient education resources, handouts, screening tools that you can implement in your organization with the opportunity to even rebrand it with your own logos and everything like that. So next slide, please. So there was two items that was sent out at the beginning or the end of last month. The first was a pre-training assessment or a pre-test. And this was a tool that we really wanted to utilize to assess pre and post knowledge of sepsis. It is optional to send it in to us if you would like, and if you're able to. If you can, Barb's email's right there if you have the ability to scan it in or to snap a picture and email it in. But either way, this will be available in the toolkit. You can use it for your staff. So if this ends up being a program that you deploy, and we hope you do deploy, program-wide, you can use this as a way to measure training effectiveness and needs for ongoing training with the pre and post test. We will also review this test at the end of today's training module. Next slide, please. All right, and the other thing that we had sent out was this Faces of Sepsis video from the Sepsis Alliance, and hopefully you had a chance to watch that. The Sepsis Alliance was created really to raise sepsis awareness to the general public and healthcare professionals. And some key takeaways that I got out of this video was that sepsis kills more people than breast cancer, prostate cancer, and AIDS combined every year. And I don't know about anybody else on this call, but I'm confident that my non-clinical friends and family probably don't even know as much about sepsis or have heard the word sepsis as much as those 3 diagnoses. So really, outside of just raising general awareness, we hope to also spread best practices, which has really been, it's been hitting hard in the acute care setting for quite a few years now. We've talked about, pay for performance and payers saying eventually this is going to be something that if compliance, we don't hit a certain compliance, you're going to get a ding. Or we talked about accreditation and the Joint Commission is going to look at this. But we really haven't talked about making it a pay for performance outside of acute care. And I have no idea if it'll ever hit that, but really part of what we hope to do is continue to spread, knowing that the majority of sepsis cases starts outside of the hospital. And sepsis awareness does save lives. Only 58% of American adults have ever heard the word sepsis. So next slide, please. So what is sepsis? Sepsis is a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. And it can result from any infection, from a common infection to a more severe infection. And if not detected early enough or left untreated, sepsis can lead to multi-system organ failure and even death. And the term is used to describe when infections get so out of control that it causes the body to shut down. Sepsis is also a leading cause of death and healthcare spending globally. Next slide, please. This slide outlines some key statistics from the CDC. As I had alluded to, 80% of sepsis begins outside of the hospital, which really justifies the extreme importance of raising sepsis awareness and education in the home health environment. Somebody had mentioned when on this call, we feel that we're doing pretty well in the acute care setting. We feel like we have these standing orders in place, the lactate, the repeat lactate, maybe fluid boluses, maybe we're doing vasopressors well, we're reassessing after all of these interventions. But what about the 80% that starts before they even hit the hospital doors? And that's really the why behind we're doing, a lot of this work. 7 out of 10 patients with sepsis received or recently used healthcare services or had chronic diagnoses requiring frequent care. And the 4 types of infections are actually common infections that are linked to sepsis. 35% were lung infections, things like pneumonia. 25% urinary tract infections, maybe leading to pyelonephritis, ultimately going into the blood, resulting in sepsis, severe sepsis, or septic shock. 11% a gut infection or gastrointestinal, and 11% had a skin infection. I know that there's a wound care director on the call. I just heard that. So one of the top 4, skin, they're very important. And actually in a later session, I believe month 3, we're going to dive deeper into wound care and the importance of skin care to prevent sepsis and best practices for infection prevention. Next slide, please. So this bar graph is depicting the hospitalization rate of patients with sepsis or septicemia per 10,000, and it's split up by male and female. And what it's really depicting is that there's no significant prevalence of sepsis among gender, but as you can see, as we age, the prevalence of sepsis exponentially increases. So if we start at under age 65, you're looking at hovering somewhere around 9 per 10,000 population, times 8, 65 to 74, 8-fold increase, going up to a rate of 70. And then if we go to age 75 to 84, it's almost quadrupled again, or I'm sorry, doubled. And then another increase for 85 and older. So just more evidence that it's linking back to the care of our older adults, and that the medically frail who already have chronic comorbid conditions are at high risk for morbidity and mortality. There is ways to risk stratify, patients by age, and this is kind of just setting us up for future educational offerings on what we'll be going through. So next slide, please. So sepsis is the cost of sepsis. I mean, can't talk about healthcare without cost, right? I mean, it is the number one cost of hospitalization in the United States. And it accounts for $62 billion spent annually. I mean, that was updated in 2019. I forget, and I should have researched this before this class, but a few years ago, it was significantly lower. I mean, significantly lower, because I remember reading this new stat that came out in 2019 and just seeing the huge increase. And, you know, who knows what contributed to that increase? Was it the huge focus on it now? You know, it's been a big focus for the past 10 years now. Are we identifying it now? Is it being coded now in the acute care setting? Are we appropriately billing for it? You know, I don't know the answer to these things, but we all know that oftentimes they're much more complex than a singular answer. The average cost per hospital stay for sepsis is double the cost for other conditions. It's the number one cause for hospital readmissions. And despite all of this, most Americans have never even heard of sepsis. Next slide, please. Even more evidence, just to kind of reiterate the graph earlier for the elderly. The elderly constitute 1/5 of the US population, but 2/3 of patients admitted to the hospital with sepsis. 1/5 of the US population, but 2/3 of patients admitted to the hospital with sepsis. And the risk factors that are specific to this is because, I mean, not only just age, but chronic comorbid conditions. They're more prone to UTIs, which is a very common source of sepsis, malnutrition, increased incidence of colonization by drug-resistant bacteria, and declining immune functionality. Next slide, please. So this slide is, let's take a moment to discuss the impact of sepsis on the elderly. So older adults that end up being impacted by sepsis, they're more likely to be admitted to the ICU than younger adults. They have a higher mortality, and in the old elderly, meaning 85 plus, their mortality risk even increases more. Longer lengths of stay in the hospital, post-sepsis impact, or also known as post-sepsis syndrome, which we will talk about in later educational offerings. It contributes to both short-term and long-term cognitive decline, as well as long-term disabilities, walking, activities of daily living, and independent activities of daily living. Next slide, please. So this slide is kind of the introduction, meat and potatoes, and now that I've kind of learned a little bit about the professionals on the call today, it sounds like a lot of people actually have a pretty strong foundational understanding of sepsis. I'm still going to give a high-level basic overview in the event that we need a quick refresher, because I'm not going to focus heavily on things like septic shock today. Septic shock is something that is very heavy on the acute care environment. That likely in the home care setting, you may or may not have access to vasopressors. I'm going to make the assumption, I don't have a lot of home health experience. I'm going to make the assumption that you don't have access to vasopressors. Eric, you can correct me if I'm wrong when you take over. But so really, let's think of this right now in 3 buckets: infection on the left and systemic manifestations of infection. So you can see that those 5 items: temp, heart rate, respiratory rate, whites, altered mental status, and blood glucose. Those are systemic manifestations of infection. Those are indicators, clinical indicators that, coupled with an infection, may point towards more severe infection. Now, the first 4 are SIRS criteria, or systemic inflammatory response syndrome. If a patient has a confirmed or suspected or a clinical suspicion of infection, so a physician, a clinician, a nurse suspects that an infection is present, plus 2 or more of those SIRS criteria equals sepsis. So temperature greater than 100.4 or less than 96.8, heart rate greater than 90, respiratory rate greater than 20, whites greater than 12, less than 4, or greater than 10 immature neutrophils. So infection or clinical suspicion of infection plus 2 of those SIRS criteria equals sepsis. Now, to progress to severe sepsis, which is the third item on the right, you also have to have organ dysfunction, hypoperfusion, or hypotension. Again, kind of relating this more so to the home care environment, I don't know if you're going to have immediate access to stat labs to look at renal function, that's relevant in the last hour, or hepatic function, or to look at declining or, respiratory function. However, we always have access to a blood pressure. And one of the most common signs of organ dysfunction is hypotension, as evidenced by a systolic blood pressure less than 90 or a mean arterial pressure less than 65. Okay, so really, we want to focus on, just for today, infection, sepsis, severe sepsis. Next slide, please. Okay, so little overview. Infection. I won't read the definition. We know what an infection is. Sepsis is an infection plus 2 or more SIRS. Severe is that 2 or more SIRS plus that organ dysfunction. And shock, again, a little more complex than this. Is a very generic definition. It gets much more complex than this, but pretty much after you've initiated a 30 milliliter per kilogram fluid bolus, or you've initiated some sort of a vasopressor, if you're still hypotensive or your lactic is greater than 4, then it is technically, clinically septic shock. Next slide, please. Okay, so really the cornerstones of multidisciplinary management of sepsis: prevention, talking about it, raising awareness, screening and early identification. Eric had mentioned that they still, this has been a high priority for his organization for a while now, and screening was at low compliance, and he's been at 100% consistently for a long period of time. Screening, the early identification, early intervention saves lives. Initial resuscitation bundle, septic shock bundle at the hospital. Again, probably not going to focus too much on that. Next slide, please. Simple measures you can take. 1, the best infection prevention measure we all can take: practice good hand hygiene, try to avoid infections, treat infections promptly. I should have put, antimicrobial stewardship there as well, making sure we're using appropriate antibiotics and using our antibiogram, getting vaccinated, and maintaining overall good health. Next slide, please. Okay, so really, in the 15 minutes that I'm going to be talking to you today, 3 things to remember: early identification, early antibiotics, and early fluids. Those are the 3 keys to sepsis. Identify antibiotics and fluids. Next slide. Here are a few studies on antibiotics and their clinical impacts on delaying antibiotics. In one study, it showed that each hour that lapsed between a patient presenting with sepsis and antibiotic administration was delayed, there was a 9% increase in mortality. So if a patient presented with sepsis at noon, by 1 p.m., there was a 9% increase in mortality. By 2 p.m., another 9% increase. By 3 p.m., another 9% increase. It's a drastic increase with each elapsed hour between delaying antibiotics. In another study, it also showed that each hour while antimicrobial administration was delayed, 8% increase to progress to septic shock, which makes sense, right? And it's pretty close, 8 and 9%, progressing from severe sepsis to septic shock, ultimately leading likely to organ dysfunction, multi-system organ failure, and if left untreated once hitting septic shock, very likely death if left untreated. Patients who progressed to shock had significantly worse outcomes, particularly around hospital length of stay. Almost 18.7 days versus 9.6. So length of stay doubled. Mortality rate, 30% versus 7%. Antibiotics are key. Next slide, please. I'm not going to go over this slide too much. This is just kind of something to keep in the packet, kind of talking again about antibiogram, what is available to you, something to consider being a home health agency. I'm going to make the assumption that most things are at the pharmacy. You may or may not have a backup box anymore with antibiotics. Don't have a ton of home care experience. So on that aspect, pretty much when would it be appropriate just to activate emergency response versus waiting for antibiotics? And that's just important for staff to know. If we have a patient with a clinical suspicion or a known infection, known meaning they're already on an antibiotic, right? And they have 2 SIRS criteria, their blood pressure is starting to dip, is it time to activate emergency response? Next slide, please. Early fluid resuscitation is the second key. One study showed that there was an increased mortality rates the longer we waited for fluids to be administered. So if we waited 30 minutes to administer fluid for patients with severe sepsis and septic shock, so they've advanced out of sepsis, they are experiencing organ dysfunction and likely hypotension and severe organ dysfunction. 13% increase in mortality rates. Up that to 31 to 60 minutes, 16%, and that progressively gets larger to nearly 20% with greater than 180 minutes. In another study, after adjusting for confounders, the higher proportion of total fluid received within the first 3 hours was associated with decreased hospital mortality. Next slide, please. So this first slide is actually speaking, or this first study was actually speaking to hydrophobia, or the fear of fluid volume overload for patients that are at risk for it. So patients with congestive heart failure, patients with chronic kidney disease, particularly those on dialysis. And as you implement some of these, and again, I am going to find it probably to be a rare incidence that we're giving large volumes of fluid in the home care setting, but if that should be the case, and there is concerns of that, there has been significant studies showing that fluid can be removed, and patients that receive at least 2 liters of fluid with those conditions, heart failure and kidney failure, they have better outcomes than patients that do not. In another study, early fluid initiation was associated with significantly lower hospital mortality, ventilation rates, admissions, and length of stay. So again, very high level overview, really trying to hit home, early detection, antibiotics, fluids. We don't have access to those antibiotics or fluids, and somebody is in severe sepsis or septic shock, we need to get them to the appropriate level of care to get them access to those resources. Okay, I'm going to go ahead and hand it over to my colleague Eric, who will be diving deeper into integrating this into the home health environment.
Thank you, Josh. Great overview. Just to follow up on a couple of the things, Josh is right. The agencies, a lot of them don't have the capabilities for mass fluid administration or antibiotics in the home. But the key is, and sometimes it gets confusing with this course, because number one, we want to reduce the readmission risk. But above that, we want to reduce the risk of morbidity and mortality in the patients that we're seeing. So screening is very important, with every patient, every visit, but also when you're wrapping it into home health care, one of the big things with the inception of the home health program for this was related to the nurse is not touching the patient every day. There's not vital signs every 8 hours or things like that. So it's really engaging the patient, the family, the caregivers, and how to self-screen and how to report. And what does that look like? How do I do it? So beyond part of this course, because we are home health care, it's engaging not only your clinical staff, but then the community. And that's where this course takes it to a different level of understanding sepsis screening, because you have a whole nother level that you have to teach. And that's important. You have to put it in patient and caregiver language so that they understand and that you can ensure that they'll follow up appropriately. So it takes it to a little different level. The other thing I want agencies to think about is thinking more, sometimes like you don't have limits. Okay, we see how the home care benefit is growing. We see right now with hospital at home, all of these things. So nothing is out of the realm of reality when it comes to this down the road. So laying the right foundation with the opportunity to improve. I mean, think about the opportunity if you are a health system with a home care, if you partner closely with a hospital, what does it look like for that patient if while you're waiting on EMS to arrive, that nurse is drawing the cultures in the labs that we know that the patient needs and is following behind EMS, the hospital, to hand them off appropriately labeled with the requisitions, some type of safe handoff process, where now we can just start antibiotics. We have pulse, we don't have to wait for anything. That's like, door to treatment time, 0 minutes. So imagine a world where that could potentially happen. So nothing's out of the realm of reality, but we also have to work within the confines of what we're allowed. The other thing is, it was, I think, Lisa who had commented about, what is kind of the culture of the community. And here in the Southeast Michigan area, the Detroit metro area, for example, with the skilled nursing and the home health providers, you can even be on a clinical or preferred, it's not preferred provider, but you'll know what I mean, a recommended home care agency for the health system if you have not completed the sepsis course and have sepsis protocols within your agency. That's how important the health systems around here are taking that. So the Detroit Medical Center, Henry Ford, Beaumont, the Trinity Health System. So it is kind of a foundation of making sure that these patients are getting cared for, and that we're all on the same page. So now it's just taking to the next step of how do we improve that coordination even further. So there is a and within the post-acute community here and the care transitions teams within the health systems, this is high priority. So it's really been made known. So what we'll go through is the home care sepsis screening tool. I highly recommend that you use this tool. So it's using SIRS criteria, but you use this tool to train your staff and they become familiar with it and the assessment and the questions that it's answering. If you can build it, I know Home Care Home Base, you can build it into your EHR. Some of the other ones is a little bit more difficult, but it can be done. As well as we'll provide you with a flow sheet to get you started too, so that it can fit somewhere up to 27 clinical visits on it, so that you can do, it's just kind of a quick checkbox old flow sheet that you can put right in the admission packet that you provide patients. But as far as training, I recommend using this easy to read one piece of paper tool so that you can kind of work through some of your first screenings with patients. Remember that the tool is standardized screening, and that's what we're doing. So we're taking a standardized screening element and putting it into our assessment practices. As far as implementation, it was easy to say we got zero pushback. Every agency that's taken this course, there was zero pushback on implementing the screening tool. Actually, clinicians were more excited about it because for once they didn't have to focus on a change in the OASIS or a change in the condition of participation or something that they have to do. They're actually getting true boots on the ground education and advancing their clinical knowledge and assessment skills. And so it was no pushback. We didn't get any reported pushback. And I'm not fabricating that. Barb can back me up on it later on. But so we'll go through the screening tool. So next slide. So the first step, and Josh already touched on this kind of in the background information, but the first step here is, do we suspect infection, or is there a recent infection or current infection that we're concerned about with the patient? So that's the first step for screening. Next slide. The next step is looking at criteria. So has the patient met the SIRS criteria for sepsis? So it is signs of sepsis present. So if 2 or more are checked, then we have a concern for possible sepsis. If not, then we have we still have probably want to report off to the physician that we, number one, there is a change in condition that we didn't expect, or if it's a change, if it's a symptom of a condition that we already know the patient has, we might not need to report off. This is key. I'm just giving insight. Right here is where, if the patient screens here, we actually have the therapist staff call in to either the case manager or one of the nurses within the office to discuss the case and for next steps on what to do. We might assign a PRN visit depending on the, I'm sorry if you hear that, our fire alarms are going off in the office. I'm gonna kind of push through it. I think it's a drill. I apologize, but if it's ear piercing, we can mute for a second. So we have the therapist call into one of the RN coordinators within the office to kind of work through, next steps. Now, if the patient's very acute, obviously I'm taking this, assuming we're going step by step. If it's acute and we, suspect that the patient's very ill, then we'll want to transfer. Okay, so then we'll have next slide. We go through the third section. So if we have concerns for severe sepsis, and then when we do a handoff, we want to do a standardized handoff. I'm sorry, this slide doesn't have the severe sepsis on it. But this is where we're looking at signs of organ dysfunction. So it would just be one of these sections. So we have 2 or more in section 2, and then we have at least 1 in section 3. So is there signs of organ dysfunction? And that could be related to cardiovascular dysfunction, respiratory, neurological, or perfusion. And so the clinician assesses that to determine. What's important about this when you're assessing and reporting off for a patient who does screen positive is that you're sending the message, that the message is getting through, whether it's EMS or to the ED, that this patient has screened for severe sepsis. So that when we're doing the handoff, the workup starts when the patient hits the door. Okay, so there's no delay, there's no sitting around in triage, there's no waiting. So what we have the nurses do when we're actively seeing the patient, so nurse, PT, anyone, if this action is happening, they call a report into the emergency department to say this patient has screened for severe sepsis or sepsis concerns. So that patient does get pushed to the front, just so you know. That is important to them. That is a keystone metric that they have to meet to ensure. So when they know up front what's going on, it's easier to to facilitate or to get the patient the treatment that they need, which I think is important when you're talking about what can we do besides screening as an agency. Once the patient screens positive, the timing is everything. And that's another report, when you're calling EMS for the patient or something like that, that's another handoff to say, yeah, this is a priority one, the patient is, septic. And so that way you get the lights and sirens and you get them there now. And so what's key to the handoff is we recommend using the SBAR implementation, providing the situation, the background, the assessment, the recommendation. The other thing that's not listed on here, but I like to think of is, where is the patient right now within their disease trajectory? Is this their 5th or 6th time back to the hospital? Are we thinking more hospice care versus acute treatment of sepsis that's a result of other conditions that's never getting better? So having that conversation with the family right then and there is, okay, is this a better transition for the patient to hospice care too? And that's another thing that agencies can think about doing. Are we providing unnecessary treatment that the patient or the family doesn't want, knowing that the patient might have a terminal prognosis, and we can expect closer to imminent death, and maybe transition that patient quicker to hospice care. So that's another thought process as far as keeping the patient at home, if that is the wishes too. So thinking about those situations, especially when you're delivering your SBAR report to the physician, if the patients are refusing to go to the hospital, because a lot of us have those patients where they are screening for sepsis and they're just not going to go. So talking about next steps or potential. Excuse me. Next slide. So just before I get into the case study, are there any questions about the sepsis screening, about kind of using the screening and things like that? Great. Okay, so for the first case study, we're meeting Mr. Smith, who lives in a senior apartment building. So I'm gonna ask everyone on the call, if you just pull out your sepsis screening tool, I just want you to work through it. You might know the answer right away, which is fine. But the goal is to work through the screening tool to get a feel for it, because if you're on this call, you are going to be training your staff or working with whatever entity to make sure. So you need to get a feel for what's on the tool. How do I flow from section to section? What does that feel like? How am I going to teach this or pass this down? So it may seem tedious, but it's good to work through it. Struggling with severe osteoarthritis about 3 months ago, had a bout of pneumonia and was admitted to the hospital. Next slide. Okay, on May 25th, he underwent a total knee replacement. Following hospitalization, he was admitted for a 10-day SNF stay, aggressive rehab. Multiple times during the stay, reported swelling and redness around the incisional site. He was informed from the clinicians that it shall take time to heal. Next slide. He's recommended for home health care. He has a full-time caregiver at home until he's completely independent. Agency can't get a hold of him. We're in June now. The RN does a drive-by. He refuses, but allows for a visit 4 days later. Next slide. So we get the SOC assessment done. So I want to think about, we've had issues with the surgical incision that we know about. We've had delays in care, so we've not able to get an early assessment and treatment plan going if there is an issue. But we make that first visit, and here's what we find. He has vital signs 98/58, heart rate 112, respirations 28, oxygen saturation 92, The right knee surgical incision is red and swollen. Toes are colored with a cap refill greater than 3 seconds. Patient reports the pain 10 out of 10. The caregiver reports concerns regarding confusion, dark and concentrated urine, lack of appetite. So, like I said, some of them are pretty easy shoo-ins for screening, but let's just kind of walk through it. So, does the medical history, physical exam, or findings suggest infection? So as you kind of screen through that, and the answer is yes, we probably suspect pneumonia, UTI, potential UTI. Signs and symptoms present, I would say yes. We have the elevated heart rate, the respiratory rate, and the oxygen. Do we suspect severe sepsis? So as part of the severe sepsis screening, we have mental status changes as well as an increased cap refill and decreased urine output. So what the goal is here is obviously the patient screens for severe sepsis, caregiver education. Key here, especially in home health, advanced directives reviewed. What are the patient wishes? What do they want done with their care? Is the family involved? And this patient wants the ED. So I'm just going to ask maybe if someone could buzz in and just maybe give me what your SBAR handoff would be to the emergency room physician. Anybody? Lisa?
Let's see. Even if you just want to give it a general stab, maybe Lisa, can you unmute? It looks like you're still muted. Anyone else?
Sorry about that.
No problem.
I had to take a call from our endocrinologist, so I missed the last 2 minutes.
Oh, okay, no worries. We were going over the sepsis screen. I was just calling on, I just picked you because you probably had the most experience, but based on the case study, I was seeing if anybody could give me an example of how they would provide the handoff to the physician in the emergency room when calling in report for the patient with severe sepsis findings using SBAR tool. But if anybody else heard it, they could beep in. There's no wrong answer. Just give it a shot.
And again, if you're on the phone, you have to press *6 to be unmuted. If you want to give it a try from any of our phone people.
Well, we'll move forward and let you guys kind of think about it. I just want to remind you, what's been really good success about this course in Michigan is the engagement of people in the group. We've been able to take away a lot of interventions that different people have done, out of the box type of thinking, and as well as key things working within their electronic health record. So if there's no wrong answer, even if you're not a nurse or if you're not in the home care setting, you can still provide feedback or what you would do. It's always good to hear, but again, participation is key. Otherwise, not everyone gets the same out of the course of what everyone else would get. Just a lot of time and effort goes into putting this together and making sure that we get everyone involved and up and running and trained. So just for future sessions, hopefully we can keep everyone engaged. So the benefits of using the sepsis tool, we'll go to that slide, Barb. So the patient receives the necessary care in the hospital, when we are quick to action, reduces length of stay, efficiency in care design and processes, which reduces Medicare, the use of Medicare dollars, and the patient has a good recovery. So I think that is really key in understanding standardized screening and being consistent with it and building your procedures within your the environment in which you work, so that you have great follow-up care and transitions. Next slide. So this one's a little bit quicker, straightforward. You have a patient underwent mitral valve replacement on 6/6. He had a 7-day hospital stay following the procedure for fluid overload. Post-op day 7, was discharged to rehab, extended therapy, demonstrated significant decline in mobility and needed additional monitoring of fluid status. Upon arrival, temperature 99.2, pain 4 out of 10, heart rate 95, respirations 22, blood pressure 150 over 98. He had a 13-day stay in the facility and made progress, and he demonstrated stability with fluid balance. Vital signs discharge, heart rate 55, respiration 16, blood pressure 140 over 85. Is discharged home to his daughter. So next slide. So the initial assessment, heart rate 85, respiration 16, 140 over 85, oxygen 95%. We do the screening, no suspected infection, so we stop there. We have the negative screen for sepsis. Everything looks good. His assessment's consistent with his discharge, which is really good to see. We don't always see that. Oh, next slide. Really concerned about the home environment with the animals and the unkeptness. So we'd make a return visit, and we have some concerns. Increased work of breathing with saturations at 92%, elevated temperature 101.8, and the other vital signs: heart rate 98, respirations 26, and blood pressure 100 over 62. So let's just work through our sepsis screening here. So the nurse suspects infection, is what they're saying. So that's a yes. The signs of sepsis present. So can anybody give me the signs of sepsis that are present for this patient?
Can you go back to the previous slide? Sorry, I'm a visual person. I can't always recall.
Oh, I'm sorry. Next slide. Next, Barb, go to the slide with case study right here. So here's our next visit. We have a saturation of increased work of breathing, saturation of 92%, and an elevated temperature.
So really all of his vitals are indicating sepsis to me.
Correct. And then are there any signs, I know the answer is on the slide, are there any signs of organ dysfunction?
Not that we're aware of yet.
Yes. So the plan here is to call the physician, kind of conference with the patient and the physician to see what our concerns is and next steps. So the physician has reported they don't want to send them in. They ordered labs, lactate and CBC, and they have a visit for the doctor the next day. The physician's findings are aligned, and the patient is transferred to the hospital and is admitted to observation for pneumonia. Next slide. Next slide. Oh, one more back. So, so this is a good example of a patient who's transferred to the hospital where they try to manage, the risk on the outpatient side. We don't know what that conversation was, but we all know those conversations happen where the patient or family, they don't want to go to the hospital. They want to try to do what they can on the outpatient side. And we are seeing that more and more. So it's not out of the realm of possibility where this patient, was only admitted to observation and returned back home. So I think you can see that though the screening is you're going to have positive screenings, the disposition of care might be different than what, is recommended based on the screening. And so from the community side, we have to kind of learn how to audible and shift our interventions and plans and orders to kind of manage that patient based on what their, based on what their preferences are for treatment. And so you can kind of see how that was worked throughout the case, but knowing that there is that inherent risk associated with it and building that into your education plan and your monitoring plan for the patient. The nurse went back a physician visit was scheduled the next day, or the nurse could go back the next day and do the labs and things like that. So we do have quick labs on board and ready to monitor. So any questions on kind of those case studies or the screening or the outcomes of the screening? Just recognizing that the outcome of the screening isn't always going to be what we think, as far as intervention wise. So again, alluding to what Josh had talked about, no, we're not going to be, bolusing a bunch of fluid and vasopressors, but we're going to have to shift to provide the best treatment possible for the patient at that point in time based on their preferences or wishes.
Eric, I have a question for you.
What's that?
This is Lisa Wood. I have a question for you on this study. I don't know what is allowed in the home care setting, but would you ever consider or be able to do a more aggressive resuscitation on this patient in the home?
Yep, absolutely. It's based on the home care's policy. So, like for example, we do IV hydration here.
Yeah.
We've taken very strict precautions and labs and quick monitoring, but we'll do it. If the patient's if we're doing an IV antibiotic, we kind of have a stricter protocol. If they've had the IV antibiotic in the past, we'll definitely do it. Where it runs a little dicey is if they, you administer IV and they have a reaction. But we also do stock epinephrine. We have an epi protocol, so we could build on that more as an agency. But yeah, you're seeing this right now with hospital at home, and more aggressive treatments for these patients so that they can really stay at home.
Yeah, because you wonder if that antibiotic and quick fluid resuscitation might have just kind of halted things. And you just don't know, but I don't know what you can do in a home care setting.
The other thing is starting, if they're not, they don't want to go to the ER and you don't have an IV antibiotic protocol, start them on an oral, this patient started them on a Levaquin, pending that his kidney function looks good. You got kind of a strong antibiotic there, and see how he does. That wouldn't be crazy.
Okay. Thank you.
Mm-hmm. Any other questions? Great. So next slide, action plan. So we'll kind of wrap up today, and we'll kind of go through the action plan. One more slide. So what we'd really like, to take away from today is start to just think and build what your sepsis program might look like as far as implementing in your agency or your setting or whoever you're partnering with. and remembering that the key thing to this program is we don't want you to just take away that, oh, now we're doing sepsis screening, but hopefully, especially with the agencies and your QAPI requirements and, looking at COVID-19 and things like that, or other respiratory infections, you can build a strong quality improvement initiative. I mean, I think if we all look at our hospitalizations in relation for their reasoning, obviously, yes, we'll see heart failure, but you'll probably see a significant amount around infection, and then breaking that down into what type of infection are they being hospitalized with. So you're hitting your big bang components of the conditions of participation for quality improvement. You're building your infection prevention and control plans within your quality improvement initiatives. You're breaking down and you're looking at hospitalization. So what are my high frequent hospitalizations related to infections? And I'm putting a plan in place to reduce hospitalization risk related to those particular infections, as you see, you'll build through this. And so you won't just be you'll be avoiding just education as an intervention, and you'll be implementing real procedural policy and procedural based interventions that will hopefully improve your outcomes for a specific measure. So make sure you take away the QAPI initiative from this so that you're not doing extra work. And I think everybody who has taken this course has found a significant QAPI area where they're meeting improvement. So, and part of sepsis screening, remember, we have to, how do we do ongoing infection surveillance? Okay, so that's a condition of participation. The agency is performing ongoing infection surveillance of patients. How do you do that? Sepsis screening is not a bad way to do that, right? So if you have that documented in every visit note, or you're showing you're building a plan for that, you just tick the box as well on the condition of participation, and as well as your site visit. So think about those things when you're building this. We're trying to create this comprehensive package for you. So before the next session, what we hope to do is that you get your team together to create early recognition process, get medical staff support for screening and early intervention. You have the screening tool, start to define the frequency of what that looks like. I wouldn't recommend rolling it all out at once, but start to look at, which staff, who's my champion on this in the field, who will take it to 5 patients and do the screening and give me feedback. I'd pick someone from each discipline. Surprisingly, my quickest uptake was speech therapy. They were all on board, and I think one of the reasons was we have 7 speech therapists. One of them had a parent who had died from sepsis, and so it kind of motivated that team to get up and running and building this in their visits. They deal a lot with aspiration and aspiration pneumonia, so it was kind of surprising, but they had quick uptake of this, and were the first group that was actually 100% compliant across the board. And then defining the content for your staff education. So step 1, 2, 3, and 4 is basically getting your team together and what is this going to look like. Anything that says develop a tool or develop a screening, we've already given that to you. So that step's been completed. You just have to, and the frequency's been defined. And now it's starting to build your team, bring that back. What do we want our program to look like? So basically, before the next session, getting the group together and creating your wish list of what is this going to look like? What do we hope to achieve short-term, long-term? How to outreach to the community and things like that. Any questions on the action plan? So really focusing 1 through 4. Great. Next slide. That was kind of what I went over. just to pick 5 patients to screen 5 visits. I don't really say 5 patients. It's really pick 5 unique visits if you can. It can be anyone. If you need a coaching call, it's optional. You can email Barb, who can reach out to Josh or I. We're happy to provide input. This is my 4th class for this, so I've got a huge list of things that different agencies have done, all different sizes, all hospital, freestanding, different EMRs. So we can always help, kind of guide you in that. If you're having questions, if you're having pushback or things like that. I always say if you have pushback, just remember the COPs, okay? You have to meet the conditions of participation. And so this program will do that for you in a one-stop shop very easily, as well as remember the end outcome is we're trying to save lives. We're trying to reduce morbidity. We're trying to keep patients in the community. And then next slide. So that's just the education materials from today. The toolkit is done. They're just finishing the branding of it. So that'll come out before the next session so that you all will have it. The educational toolkit is a great thing to provide patients with written instructions, another condition of participation for their current, how are we managing their current risk of sepsis or their current infection. We tried to make it very specific to what you're doing for the patient when you would utilize it and things like that, so that you're not just giving them unnecessary pieces of paper, but actually building it into your teaching and training plans on the home health side. It can easily be used on any other community side as far as the AAA organization and providing to patients. It's just having someone to teach them how to use the toolkit and what to monitor. So we'll get into that the next session. So next slide. Resources. You all have the slides, so the resources are on there. Next slide. And then open for questions. We have like 2 minutes, 4 minutes. If no questions, then I will give it back to Barb to wrap up. Thank you.
Yeah, just a couple quick housekeeping things. We will, after today's session, I'll send out the screening tool and the action plan copies for you. That will be all included in the total sepsis toolkit that you will, as Eric mentioned, we're just still tweaking a few things on it and getting it rebranded for use. But that'll have all the PowerPoints, all the documents that we talk about in it. But for today's session, I will send out the PowerPoint slides, the screening tool, and the action plan for your use. And then thereafter, it takes about a day or so. The recording from today's session then will go out within the next day or two because of downloading. It just takes a little bit, but you'll get that shortly as well. And then also, we had you take the pre-test. As Josh said, we would like a copy of that. Again, it's just sort of also to sort of measure our training and areas for improvement, where people were at the beginning of this course. And then we'll give you the same test at the end to just sort of measure your learning. And it just is one way of us sort of seeing how the training is and if it went well and met your needs, as well as maybe areas for improvement. We will also include an evaluation at the end of the whole course, where once you complete that evaluation, you just get a certificate of attendance. As Eric mentioned, some places in Michigan are wanting that for participation in certain health systems in their preferred provider list or whatever they may be calling them, or you may need to have that for other reasons, and we will make sure that you get a certificate of attendance. I do apologize. I know one person had a difficult time joining today. Just for your reference, you should have had individual invites sent to you for the next sessions. Those were Thursday, September 9th. That's 9 Central, 10 Eastern time. It should be in your calendar. October 21st, again, 9 Central, 10 Eastern, and November 18th is our last session. They are all on Thursdays, but they were individual calendar invites to you for this meeting. If for some reason you do not have them, reach out to me and I'll get you connected so you have those in your calendars so you can attend all future sessions. I think that's everything, unless I missed something, Josh or Eric. Okay.
Barb, thank you.
Okay. So again, look for that email. I'll send all documentation that we talked about today in that email later on today, so you can get going with your action plan and the sepsis screening at your particular organizations. I hope you enjoyed today's session. I, as a social worker, always learn a lot about sepsis every time I attend these. So I know it's an incredibly important condition, and I'm so happy that we can provide this training for everyone. Again, if you have any questions in between time, email me and I'll get you connected to Eric or Josh. They can provide some support between the next session. That's September the 9th. And other than that, anyone have any other questions at this point? Okay. So with that, we will end today. Thank you, Josh and Eric, and thank you all for your participation. As Eric said, it's that much better of a training if you do participate and just take a risk. We're here. It's a no blame area. We just want to learn from everyone as well. Okay. Well, looking forward to seeing you on September 9th. Again, my email, I will quickly chat it in for you. Sorry, my chat functions. It's blink@mpro.org. So any questions, just email me and I'm happy to direct you to the correct person or answer your question. And looking forward to seeing you Thursday, September 9th, 9 Central, 10 Eastern. Thank you all.